recognized experts. We hope this will inspire growth, collaboration, and improved patient care. We aim to provide opportunities for learning, sharing experiences, and discussing the latest advances in the field. It's my honor to introduce today's speaker, Professor Vincent Mosca. Probably he doesn't need because he has been more than fifth or the sixth time to this platform. He's emeritus professor at Seattle Children's Hospital, and he's a leading expert in the field. His book on pediatric foot problem is widely recognized as a Bible or a Quran or a Gita, and it's now in its second edition. Everyone who is planning to operate a case of pediatric foot problems should read this book, and that will give you a lot of insights about the problem. The topic for today's session is congenital Hallux varus and pre-axial polydactyly and Kohler's disease. I know that it's a rare, but they are really challenging conditions. And we are going to learn something in the form of interaction. I would also like to thank OrthoTV for providing us this platform to support this academic event. So with that, I hand over to Professor Mosca. Over to you, sir. Thank you.
Thank you, Darren. Yes, this is I think it's the seventh time that I've participated in these talks, and I've enjoyed them immensely. This one is going to be a little different. As Dr. Ganjwala mentioned, congenital Hallux varus and Kohler's disease are really quite rare in comparison to the other talks that I've given on flat foot and cavus foot, tarsal coalitions. But there's a lot to learn from them. And although they're uncommon, they're not unheard of. So when I started putting the talk together, I thought, how can I make this interesting? I hope it's interesting. And I think what's going to make it more interesting than just the presentations, excuse me, than just the presentations is the case presentations. So Dr. Ganjwala and Dr. Hitesh Shah provided me with several case examples that bring out points related to congenital Hallux varus, although most of them are not exactly congenital Hallux varus, but they have some similarities. So by discussing them as cases, we should reinforce the points I make during the didactic portion, and also I think expand beyond the topic of Hallux varus into assessing and then using the assessment to manage foot deformities in children. So this is 2 feet. The hallux, or the great toe, is in varus alignment. It's angled inward. So we call it congenital from birth Hallux varus. We don't know the incidence, although it's usually isolated, but it may be seen with syndromes. So when you see this, and you could also see a simple syndactyly between the second and third toes, you need to perform a full assessment of the child. Is it isolated or is it syndromic? The management will probably be the same, but it's always important not to focus just on the foot or the toe and focus on evaluating the child. These are the x-rays. And just as in looking at the photos, the first thing your eye draws you to is the fact that the hallux is in varus alignment, right? But if you look more carefully, there's something else that's not normal. And what else is not normal is actually much more important than what you have just been thinking about. Because many cases, we don't know the frequency, but many cases of congenital Hallux varus are associated with first metatarsal longitudinal epiphyseal bracket, LEB. How do you know that this is a longitudinal epiphyseal bracket? Well, the lateral cortex of the metatarsal is concave and it's sclerotic. It's got a dense white line, which means cortex. If you look at the distal, medial, and proximal surfaces of the ossification center, you don't see that thick, dense cortex. It looks more subchondral. It's the kind of bone quality you see under an epiphysis. So on the lateral side, we see concave, and on the medial side, we see convex. That's what tells you, and the fact that the bone is shorter than you expected and fatter than you'd expect it, wider, you know that there's something else going on here. Again, you looked at this first, you saw the toe, great, let me straighten the toe out. But this is the thing you cannot ignore. So here's a case of pre-axial on the medial side polydactyly. There are two great toes. That metatarsal also looks very strange. It has a straight to slightly concave lateral surface, and medially it looks like a C. Or perhaps if you make the C with the line down the lateral cortex, it's a D. And I drew it that way with the hollow inside of the letter C that you can understand better by looking at this MRI scan. That is the growth plate of the first metatarsal. The growth plate of the first metatarsal should be proximal. The growth plates of metatarsals 2 through 5 is distal. But the first metatarsal should just have a proximal growth plate so the bone can grow longer. But that's the cartilage, that's the epiphysis on this metatarsal. And if the epiphysis and physis wrap around the ossified portion of the bone, it's going to grow that way and that way. But we don't want it to grow that way and that way. We want it to grow longitudinally. We want this to be the situation, which is normal. The epiphysis and physis are proximal, and so as the physis makes more bone, the bone grows longer. So I showed this before. This is bilateral congenital hallux varus with first metatarsal LEB. LEB is associated with hallux varus and also with pre-axial polydactyly. I did a study that my fellow has been slow in finishing up. I had 61 cases of pre-axial polydactyly. 21 of them, a full 1 out of 3, were associated with longitudinal epiphyseal bracket. 1 out of 3. So common. And just like isolated congenital hallux varus, if a child has preaxial polydactyly with varus alignment of the two great toes, it's so easy to be distracted by the toes and ignore the longitudinal epiphyseal bracket, which long-term, untreated, will be much more disabling than any varus deformity or any extra toe. It's the LEB that must be treated initially, more important than the deviation of the toe. Here is a case, now almost skeletally mature adolescent who had untreated longitudinal epiphyseal bracket. You can see how big the ossification of the first metatarsal was at birth. You can see the stress transfer to the second metatarsal because those short first metatarsals were not weight-bearing. So the second metatarsals are long, thick, and sclerotic. That's where the weight bearing is going rather than being shared with the first metatarsal. And I outlined the now ossified bracket epiphysis of the first metatarsal. So it's a short, wide bone, primarily made of cartilage that is now ossified in a C fashion rather than just at the base. Here's a case of a child who had unrecognized hallux varus and longitudinal epiphyseal bracket, and the surgeon had, no, I don't think this child had ever been treated, but at age 5 was diagnosed with hallux varus and the LEB, underwent resection, and simultaneously had a first metatarsal opening wedge osteotomy. That was the largest graft that could be put in. And at age 13, the bone was growing. You can see that the metatarsal is longer than it was at the lower left, but it certainly has not caught up with the second metatarsal, which still shows evidence of overload because it's thick and sclerotic. This bone will need to be lengthened to treat the pain that's under the second metatarsal. Look at that overload. Pre-axial polydactyly. Again, this is a case where the extra toe had been removed and the longitudinal epiphyseal bracket I think the surgeon attempted to remove it because the medial cortex looks odd, but he certainly, or she didn't, was not effective in establishing longitudinal growth overload. But this is what it looks like. Pre-axial polydactyly on the upper left. That's what the cartilage looks like. Distal, medial, and proximal. And those two wires outline the segment that's going to be resected in purple, which you can see below, where those two small gauge needles were placed at the limits of what was going to be resected. And there, the abnormal cartilage is removed from the medial side of the first metatarsal. It's thick. Even in a small foot like this, it's about 1 centimeter thick and 1 centimeter tall from top to bottom. 2 years post-op, you can see not only is the bone growing, but it's remaining parallel with the second. The great toes are parallel. And 4 years postoperatively, again, you would have to look really carefully to see if there were a problem. The first metatarsal is often a little shorter than the second, and this is anatomically normal relationship between the two bones. Had it not been resected at the time of removing the extra hallux, this would be a short bone. If I had been effective, if I had been successful in resecting the coalition and it were growing, it would not catch up to the second. So the point is, the earlier you identify a longitudinal epiphyseal bracket, the earlier you remove the abnormal medial growth plate, the more equal the lengths of the first and second metatarsal will be. Another case showing, in this case, I wanted to again show how thick the abnormal cartilage is. It's about 1 centimeter tall, 1 centimeter wide. And this on the lower center, I hope you can see my cursor. Can you see my cursor?
Yes.
Anyway,
Yes.
yeah. So this is the dorsal cortex of the first metatarsal. This is the plantar cortex. So when the abnormal growth plate is removed, you see subchondral bone, just as if you had a Salter-Harris type 1 fracture, and the epiphysis had moved, you'd see subchondral cancellous bone. Well, that's what we see on the side of the first metatarsal. This is the dorsal cortex, that's periosteum, and on the plantar surface, you stop when you see cortex and periosteum. This is a case very similar, but not the same one. Remove the extra toe, remove the abnormal cartilage, and look over time. You can see a cortex has developed. The bone is growing. There's residual hallux varus, but with time, some of that varus deformity has corrected, not all the way. The bone is definitely growing, keeping up with the second metatarsal, but the child still had varus deformity and a short bone. So several years later, performed an osteotomy of the first metatarsal, put in a trapezoid to correct both the angulation and to try to increase length. These people only accept so much bone at a time, and here during healing, later and later. So this relationship in length between the first and second metatarsals is not perfect, but there's not much stress overload on the second metatarsal. It's not sclerotic. Clinically, there's not much callus formation under the second. And although this child may have required another lengthening later on, we've come a long way between the upper left, the upper right, and where we are now with a corrective osteotomy following the initial and early elimination of the abnormal growth plate. One other feature that I sometimes see in congenital hallux varus is that they have a medial fibrous band. And this is regardless of whether there's a longitudinal epiphyseal bracket or of the first metatarsal or not. It's just a dense fibrous band. It looks and feels like a ligament. It's connected from the medial cuneiform to the hallux. So in this case, it almost looks like a webbing of the skin, and right under that skin is this fibrous band. So you obviously can't see that on X-ray, but after you have your X-rays and then go to perform the surgery, you'll identify this and remove it and do what other procedures are necessary at the time, such as remove the LEB if it's present, align the hallux if necessary, and again, dial in what that particular foot has. They're not all the same. So I can pause here for a minute if people wanted to ask some questions about that. In fact, let me not do that, because the cases are all about longitudinal epiphyseal bracket. And I think if we wait until the case studies, then the questions might be applicable in real time. So let me move on to Kohler's, because this is a shorter topic. And the key here is, what is Kohler's and what is not Kohler's? So Kohler's, that affects about 80%, about 4 out of 5 cases of Kohler's disease, osteochondrosis of the navicular, 80% are in boys. It's often bilateral, but can be unilateral. This is really important. It develops at age 5, plus or minus a few years. This is a condition that happens only in the first decade of life. Beyond that, it's not Kohler's disease. Any change that you see in the navicular, not due to trauma, not due to infection, not due to cancer, any change in the appearance of the navicular in the first decade of life is Kohler's, and that same idiopathic change in the navicular later in life is not. It presents as pain, tenderness, swelling, erythema of the midfoot. Pain, tenderness, swelling, erythema. Those are all words that we typically associate with infection, right? But Kohler's is not an infection. The child typically, this 5-year-old boy typically walks with a supinated foot. He walks on the lateral border of his foot to prevent direct axial weight-bearing loading on the medial column. It feels better if he walks on the lateral border. Radiographs are diagnostic. The navicular appears to be sclerotic, sometimes fragmented, with distal to proximal flattening, everything you see in the lower right compared with the lower left, which is a normal ossified navicular in this child. Unilateral case, it looks like vertebra plana, right, in the spine. But this is one of the appearances, radiographic appearances of Kohler's disease. But the foot's painful, it's tender, it's swollen, it's red. Is it an infection? So a lot of people immediately then rush to get an MRI. On an MRI, this looks like osteosarcoma. The MRI, not only because it's expensive, is the last test you want to order. It's not going to tell you what it is, and it's going to look so bad that everyone's going to get nervous and scared because there's so much inflammation on the MRI that you're going to be stimulated to do unnecessary tests and unnecessary treatment. If you think that it's infection, which would be the second choice, then just order the blood test. CBC, sed rate, CRP, those will tell you if it's an infection. They'll be normal in Kohler's disease. And despite this odd appearance of the navicular, you can feel comfortable that it's going to be okay. So don't spend the money on an MRI. Don't scare everybody in the room with an MRI. If you think it's infection, despite what you know about the radiographic and clinical appearance of Kohler's, then just get some blood tests. So Kohler's is an osteochondrosis, bone and cartilage inflammation, maldevelopment. It isn't clear what causes it. It's probably, though, related to mechanical forces that compress the very intricate blood supply of the navicular during weight bearing and during early ossification of the navicular. Girls, the navicular is the last bone in the foot to start ossifying. It starts ossifying in girls about age 2 and in boys about 3.5 years. Boys get Kohler's more commonly than girls. These compressive forces are due to weight bearing on the early ossifying navicular during weight bearing. So if boys are starting to ossify at 3.5 years, when they're bigger, heavier, and more active, they will put more compressive forces on the bone that might lead to Kohler's, rather than girls who are lighter weight, younger, when they start walking and don't have the same compressive forces. So again, this is just theory. It's never been proven, but just know that if you have a 5-year-old boy, very active, running around, and he has all those signs and symptoms and x-rays, it's Kohler's disease. And here you can see one that is sclerotic. They can look more different than normal than that, but there's another case of it. And this is not Legg-Perthes disease of the navicular. That's very important. Legg-Perthes disease, again, we don't know what causes it necessarily, but the prognosis for Perthes is either okay or terrible. Perthes rarely goes back completely to normal with or without treatment. So although it seems to share the same pathology of, well, now the epiphysis is changing, it's sclerotic, it's all those other words, that it doesn't ever go back to normal, except in the mildest of cases. So this is not Legg-Perthes, even though it's an osteochondrosis. The other thing it's not is Mueller-Weiss syndrome. And this is, again, the other point I wanted to make, that every change in the navicular that orthopedic surgeons see, whether it's in a 5-year-old, 15-year-old, 50-year-old, is called Kohler's, and it's not. It's only the 5-year-old up to maybe age 10 with those idiopathic changes in the navicular that has Kohler's disease. Mueller-Weiss is what you can see here. It's an idiopathic and rare degenerative disease of the adult navicular. It's an osteonecrosis, not an osteochondrosis. So Mueller-Weiss is probably more similar to Perthes disease than is Kohler's disease. Mueller-Weiss never has a good outcome. Kohler's always has a good outcome, with or without treatment. And Perthes, treatment may affect the outcome. So Mueller-Weiss, characterized by progressive collapse, fragmentation, with pain and deformity, typically in middle-aged women. In my almost 40-year career, I saw 2 older teenagers who had what I call Mueller-Weiss, and they were very, very challenging to treat. Prognosis is not good. It is not Kohler's disease. It's this other condition called Mueller-Weiss syndrome. And there's a whole series of progression of what happens to the navicular. So let's go back to Kohler's. What's the treatment? It's pain relief. You can restrict activities. In a 5-year-old boy, not going to happen. You put arch supports in just to sort of unload the medial column so that the child doesn't have to walk on the lateral border of the foot and can walk with the entire foot on the ground. There was a study or two that showed that if you apply a short leg cast, either weight-bearing or non-weight bearing, that symptoms will be decreased in duration. So if a short leg walking cast is applied for 6 to 8 weeks, the child will have only a few months of discomfort rather than perhaps a year of discomfort. There is absolutely no effect on the healing of the bone or the outcome if the child is treated with a cast or not. The casting or restriction activities is only for symptomatic relief, but the outcome is the same. And what's the outcome of Kohler's disease? Excellent and normal foot, excellent and normal x-rays, again, whether treated or not. Same foot several months later. So that's it for Kohler's disease. The important points about Kohler's are it's not Perthes and it's not Mueller-Weiss. It has excellent prognosis. You can choose to treat it or not. The best thing to do is just reassure the family that things are going to be okay. And if the child doesn't slow down or won't accept the cast, then you have to say to the parents, then the child can't complain to you. They can have pain. We told you how you could feel better. If you don't want to accept it, well, then you're going to hurt for a while, but in the long term, you'll be okay. So that's it. And let me ask for questions on Kohler's disease before we get into the cases.
Yeah, the question is like if patient or the child is not responding to non-operative treatment which you suggested, is there any role of drilling the bone? Like say we carry out drilling in lot of conditions like avascular necrosis. No doubt you said that this is not avascular necrosis, but to increase the supply, the blood supply, can we do that in the Kohlers?
I think that would be malpractice. I really do. For a condition that's known to have an excellent outcome, that if you intervene, all you could possibly do is make things worse. This is not an osteonecrosis, it's an osteochondrosis. The blood is there. It's just doing whatever it does. But in osteonecrosis, one of the treatments for Mueller-Weiss is to drill it in the early stages. In later stages, you have to fuse the whole medial column of the foot. But for Mueller-Weiss, as an osteonecrosis, if you drill, you'll bring blood in. This navicula doesn't need blood. This navicula needs to be left alone because it knows how to heal. So like I said, putting a cast on may be unacceptable to the child, but if the parent has to say to the child, listen, we're going to either put a cast on and you're going to feel better, or we don't put the cast on, but you're not allowed to complain to me. I will not listen to you if you tell me you hurt because I told you how you're going to feel better if we put the cast on. So like I said, I think anything that you intervene on for this is just not acceptable.
Okay, and like what should be the duration we should tell the families that it is going to take this much time?
Say again, what was the first part of that?
How much time does it take for spontaneous natural recovery?
Yeah, so if you put the cast on for 8 weeks, usually the symptoms are markedly decreased, and in another few months, perhaps up to 4 to 5 months, the symptoms should be gone. And it's not intense pain; it's an aching discomfort.
Right. Then I have a few questions related to congenital Hallux varus treatment. Like
Okay.
you mentioned about the longitudinal bracket, but what about the correction? How to correct the Hallux varus?
Well, that's what we're going to get into. Let's get into the cases. Is that good?
Yeah.
Okay. And just tell me, this is a 1-hour session, correct?
Yes.
Okay. So these cases were sent to me for the rest of the audience by Dr. Ganjwala and Dr. Hitesh Shah. And after I received them, I modified them a little bit so that we can talk about principles. And I'm going to see if anybody else wants to make comments about how they might manage them, and then I'll tell you what I believe. What you can see here is a great toe on the right foot, which is very wide. It has duplicate toenail that are conjoined, so it's a single toenail for what's probably 2 toes. And this is the X-ray. So what do you see? You see pre-axial polydactyly. You see congenital hallux varus with a negative distal metatarsal articular angle. The DMAA is a term that's been around for maybe 15 years, and we use that to better understand, especially in relationship to hallux valgus, where the articular cartilage is on the end of the first metatarsal. So the white line, I believe, represents the first metatarsal phalangeal joint. The orientation of that joint is in varus. The normal DMAA is 0 degrees to 10 degrees of valgus, meaning that that white line should normally be either perpendicular with the axis of the first metatarsal or in up to 10 degrees of valgus. This is in 10 degrees of varus in relationship to the axis of the first metatarsal. So if this were in the opposite direction, normal, if it was more than 10 degrees in valgus, then that's considered an abnormal DMAA, but this is abnormal because it's going the other direction. This is really the radiographic definition of hallux varus. In addition, this foot has congenital hallux varus interphalangeus. So there are many people who have hallux valgus interphalangeus, where the proximal phalanx is trapezoid shaped, either because it's just a trapezoid shape or because there's a delta phalanx. Delta phalanx meaning longitudinal epiphysis of that bone. But this one we know has congenital hallux varus with a negative distal metatarsal articular angle. In addition, it has congenital hallux varus interphalangeus, so both joints are oriented in varus. And we can look, if we're thinking about the angulation of the toes, we can also look at the relationship between the first and second metatarsals. And they're normal. The normal angle between the first and second metatarsal should be less than 9 degrees. This is less than 9 degrees. So how can this child be helped? Does anybody want to make a proposal, or and then I can get into what I was thinking.
Yes, so as you said that the distal joint line is in a varus, I think the correct approach would be to go for a metatarsal and the proximal phalanx osteotomy, the medial open wedge osteotomy to correct the joint line properly.
Anything else?
Hello,
Yes,
Dr.
suppose
Saktidas.
Yes, Saktidas, please.
Because he is now a small child, what is the age now?
the age of child is 3.5.
So 3.5 years. I think we can this pre-axial polydactyly we can exercise and medial side capsulotomy with KOR fixation we can do at this early age. We'll not think about osteotomy at this age. Maybe by soft tissue procedure, we may succeed at this age and we'll try to maintain it by splints.
Other thoughts? Okay, well, those are
And then
all.
there is a divergence at the between the first and the second.
Well, the first and second metatarsals may appear a little wide, but they're not angulated. And some of that separation, I'm just guessing here, some of the separation may be due to the soft tissue contracture medially, because the skin is so tight there. So toe has to go, period. A medial opening wedge osteotomy would correct the joint orientation, but the skin is so tight medially, it's going to be hard to correct the deformities in the first place. So a lateral closing wedge osteotomy would accomplish the same thing. Whether you do opening or closing, you also need to consider the length of the bone. This is a relatively long first metatarsal. So if you do a closing wedge, you'll still maintain the proper transverse alignment of the metatarsal heads. An opening wedge wouldn't change it very much, but here you can do the closing wedge on the lateral side. It respects the fact that you need skin medially, and you get the same improvement in the DMAA. So that addresses that problem. As far as we can tell from the x-ray, there's no joint incongruity. This is not like some hallux valgus where, regardless of the DMAA, the toe is subluxated. This is a congruous joint. So you're not going to want to do anything to subluxate a congruous joint. It's a bone deformity. There's no growth plate at the end of the first metatarsal that you could damage. The growth plate's proximally. So I proposed a lateral closing wedge of the distal first metatarsal. But then you have the abnormality of the proximal phalanx as well, which you have to correct. Once again, I don't know for sure, based on the ossification centers, I believe it's a pretty congruous joint. So one can perform an osteotomy through there. And you're away from the growth plate. There's probably a delta phalanx. So when you perform that osteotomy, you can either resect the cartilage or just perform the osteotomy. I'll show a case later about delta phalanges. And now you've corrected the two bony deformities. And with a longitudinal wire, there's no risk of damaging these growth plates. The wire is going to be in for less than 6 weeks. We know that a wire can cross the center of a physis and is even indefinitely and not affect growth. That's what we do for kids who have osteogenesis imperfecta. We put smooth wires across the middle of their physes all the time. You don't want to put a screw across, but a wire is not harmful to the growth plates. So remove the extra toe, osteotomy of the distal end of the first metatarsal, osteotomy of the proximal phalanx, and now everything's looking good, except the skin is probably going to be really tight. So prepare for doing a Z-plasty of the skin before closure. And for cosmesis, and now that the bone column is straight, you can actually resect some soft tissues from the web space between the first and second toes. And so by drawing those lines, the axis of each of the bones, you can see where the deformities are. You can know where to correct those deformities. Had there been obvious joint subluxation, then you would want to address that. And we'll see that in subsequent cases as well. But in my interpretation here, there's no joint malalignment. These are bone deformities. And then you need to consider soft tissues when you do the reconstruction.
Yeah,
Any
makes
questions?
sense.
So this is the second case. And again, they sort of look like Hallux varus, but they're not really. In fact, they're both cases of polydactyly. And although you can call it medial, they're sort of central medial. Let's look at the right foot. The right foot has excellent first ray, excellent lateral forerays, and then there's this ray in the middle. That toe between the obvious first and the third one over has two phalanges, so it's a great toe. That partially formed metatarsal is the first metatarsal because it has a large head and no growth plate distally. And proximally, it looks as though it ends in a synchondrosis to the third metatarsal. So this is easy. If this was macrodactyly, you do a ray resection. That's exactly what you do. In macrodactyly, you usually leave the base of the bone articulating with the metacarpals, but the metatarsals. But here you just resect it all the way back, close it together, and no one will ever notice that this foot had a problem. The other one's interesting, and I was considering how we could make this foot more functional, fit in a shoe better without being too complex. So I thought if we removed the more lateral toe, there'd be a great distance between the first and the second. There's a maloriented MTP joint on the medial toe. There's a normal metatarsophalangeal joint with the second great toe. So I thought if we resected that and that, now we've got a great toe that is a great toe with two phalanges. Normal metatarsophalangeal joint, normal length of the first metatarsal. And even though the first metatarsal is a combination of a metatarsal and a partial metatarsal, no one's ever going to know that unless they look at the x-rays. So this would be a really easy way to correct this foot. It'll fit in the shoe, it'll look great, and this would be my proposal for treating this. Not unheard of, I've actually seen this a couple of times, but this would be the way to treat this foot. Any comments?
Yeah, it's a great plan, but what is the natural history of the remaining part? What is the fuse, the second one, the small?
That bone, most likely, I didn't see a lateral. My assumption is that
Okay.
because I've seen about 5 slight variations, but very similar cases to this. And typically the two metatarsals share the head. They're just different proximally. And so the proximal part of that little tiny metatarsal, if it were prominent palpable, you could just resect it. But in my experience, and based on this X-ray, I assume that they just form one very functional, very smooth metatarsal.
Yeah. And one more question here. The right side, there is no doubt about a centromedial complex polydactyly. But what will we say on the left side? Would you say the central polydactyly, or will say the pre-axial, or the pre-axial with central mix?
So my assumption of the definitions are
Okay.
unclear. But so 85% of polydactyly are post-axial. And there's
Yeah.
so many patterns. I mean, so many patterns. On the medial side, I always assume it's medial. It's medial to the more normal metatarsal, like cases that we've seen so far. So this is on the medial side of the foot. And it's definitely not central. It's not between the second and third. So I just figured I'd call it central medial. I don't think it matters very much. You have to have the word medial in your description, but it's not directly medial. It's medial, close to medial.
Okay. Yeah. So a few
Yeah,
more
there is a
questions.
question. Yeah, Hitesh,
Dhiren bhai,
please
go
go
ahead.
ahead.
Yeah.
Yeah, like Akash has a question, like what we need to do for the abductor hallucis.
For the what?
The abductor hallucis. There is a question in the chat, and the question says that when you manage congenital hallux varus, how do you or what do you do to the abductor hallucis?
I'm going to get to that. So this is a case of polydactyly. We have more cases of hallux varus. And
Okay, at that point we will discuss that. At
Yeah.
that point we will discuss that.
So this looks like hallux varus, but it isn't. Concave, convex. This is a delta phalanx. So when you looked at this foot, and I don't have the clinical photos, again, these are not my cases, I would say, wow, this is a case of congenital hallux varus. But based on that, we know that that D-shaped or triangular bone is a delta phalanx. It's got a concave lateral border. Medially, that's the growth plate that wraps around the bone. This is a different case. This is one of my cases. Actually, I think this is my second edition of my book. You can see a delta phalanx. It's got a concave lateral border, concave medially, have the two wires in that bracket the area of growth plate, abnormal growth plate that I'm going to resect in the forceps in B. You can see that really thick cartilage, which is growth plate cartilage that I removed from the medial side of the shaft of the proximal phalanx. So by resecting that abnormal epiphysis along the shaft of the bone will henceforth grow longer. It will not, however, straighten itself out. It will not continue to be curved. It will not continue to, it will just stay curved. So remove the cartilage so that it can grow from the ends and then perform a concurrent osteotomy to straighten out the toe. And this is one approach. It's a pretty small area in there, but if you use mini fluoroscopy and you know your techniques, then you can perform this, and that abnormally shaped proximal phalanx, a delta phalanx, can result in a toe that then grows normally and has straight alignment. And so that's delta phalanx. Now I'm going to come back to longitudinal epiphyseal bracket. This is pre-axial polydactyly on the left, and on the right, it's almost identical to the foot in the other case. So for this one, central medial polydactyly, do a ray resection. Okay, perfect. What about this one? Preaxial polydactyly, almost 90-degree deviation of the more medial duplicate toe to the axis of the foot, and a clear first metatarsal longitudinal epiphyseal bracket. So for this one, say remove the toe. The skin is probably not going to be very tight here. Unlike the other case where everything was deviated medially, after elliptically removing this toe, there's probably going to be plenty of skin, but you always want to be prepared for a Z-plasty. That's the abnormal part of the growth plate that wraps around that short, fat metatarsal. The uncolored parts are a proximal epiphysis, where you'd expect it to be, and then a distal pseudo-epiphysis. Here, I believe there is subluxation of the joint, in contrast to the other one where it was a maloriented joint. This one, I believe there is some subluxation, and that after removing the extra toe, after removing the cartilage on the medial shaft of the bone, you can translate the remaining hallux laterally to create congruity and pin it. Well, what about that small bone? It's going to, it will reestablish growth, but it's not going to catch up in length to the second one, like one of the examples I showed earlier. So the choices are to do exactly this: remove the toe, remove the abnormal cartilage, and align the metatarsophalangeal joint, or do all of that and also perform an osteotomy of the metatarsal. And I think it would depend on your comfort at the time whether you wanted to do the osteotomy. There are a lot of small moving parts if you perform the osteotomy concurrently, and you also have the unstable metatarsophalangeal joint. So I personally would do all of these procedures, and then in a year or two, when the MTP joint capsule has stabilized, then go back and do the first distraction lengthening osteotomy of the metatarsal, knowing that it's not possible to get all of the length, but if you do maybe 2 or possibly 3 segmental lengthenings as the child grows, you'll get that metatarsal to the length that you want it to be in comparison to the second. So again, if this is all you could do, or you could add the osteotomy, a lot of moving parts. So I personally would delay for a year or two for the osteotomy. Questions? And this is the case.
One
Yes.
question that how to mark with the 2 wires? How will you mark what is the putting for wire for proximal and distal wire? What is landmark? Yeah.
So the proximal wire is right at what I believe the edge of the normal physis should be. So that would be this one. When under mini fluoroscopy, I put in this 25 gauge needle at what I thought would be a nice congruous epiphysis with the medial cuneiform. The distal one, I think I repositioned this one after this photograph to come out a little farther. But what you need is, you just need a big enough gap here that the physis is not going to reform. You need to have good separation. So the proximal wire, you want to have right at what you expect to be, where the physis should be, and distally at the medial edge of the normal metatarsal phalangeal joint. But again, you have to remove enough that it's not going to reform. Is that helpful?
Okay. Yes, it's helpful. But in case where the left side same one, how would you make out the duplication of metatarsal? Because I agree the convex side and concave side, but sometimes it would be like first X-ray. Sometimes it would be associated with the duplication. It's not like C shape. The first left X-ray, the first one. So it's how we'll be sure that it's not duplication of the first first ring.
You mean that there's not a that there were not 2 first metatarsals?
Yes, it's a duplication. Yes.
It's going to be ossified.
Yeah.
Yeah. So the AP might not show it. If you're suspicious, you could get 2 oblique X-rays. So you just look around, because like you already showed a couple of cases here, there sometimes is a rudimentary second metatarsal, and it may be hidden by one view. So you get some oblique views and you can see if there's a second one there.
Okay. Anytime you need to do the MRI, what is the role of MRI? Every cases or few cases when you suspect?
I'm going to get to that too. I've anticipated everything. Okay, here. So this is what we call a floating polydactyly. It's just connected by skin, so goodbye. And the other foot is almost identical to case 1, so I would treat it exactly the same. Now, here's where we're going to, I think, answer all the rest of the questions. This is a case I actually just received this morning and was able to incorporate into this talk. Hallux, great toe, varus. From birth, congenital. So it's congenital hallux varus. Here's the x-ray. Now, you all have seen this combination several times. We've talked about it. This is a 90-degree deviation. This is one where the skin is going to be really challenging to enable and then maintain deformity correction. And so this is the surgeon. I don't know if the surgeon drew these pictures or got these from some other image. They're really beautiful images of how to do a soft tissue rearrangement for congenital hallux varus. There it's drawn on there, and there you have it. The metatarsal phalangeal joint is straight. It's been pinned compared with pre-op. And you have a straight toe before and after. But so I don't know what the surgeon's plan was, but for all of you who looked at that clinical photo and thought, got to straighten out the toe, hopefully by now you will always, when you see a case like that, look at the x-ray and say, how's the metatarsal? And in this case, this is a longitudinal epiphyseal bracket that, and again, I'm not even sure if the LEB was treated, but this LEB needs to be treated as soon as possible. That abnormal cartilage on the medial side needs to be removed because there's already such a marked discrepancy in length between the first and second metatarsals. The sooner this abnormal cartilage is removed, the sooner the metatarsal can grow. In our study, we found that there was some catch-up growth compared to the second. When we resected an LEB, there was some catch-up growth in the first 1 to 2 years. It wasn't always dramatic. It was often a few millimeters. And then after those first 2 years of growing slightly faster than the second, then they continued to grow at the same rate. So the catch-up growth was only in the first 1 to 2 years, and then they grew proportionately. So a case like this will always need metatarsal lengthening, and maybe 2, maybe 3, but the sooner you release and remove the abnormal cartilage, the sooner the bone grows and you have less discrepancy to manage later on with lengthening osteotomies. And so Hitesh, remind me again, what was the question that you had about the...
What is the role of MRI? I asked.
MRI, okay. So, yeah, I thought I had something in here. I must have taken it out. X-rays, there's no other reason for a first metatarsal to be short and fat at birth other than a longitudinal epiphyseal bracket. There's no other reason.
Yeah.
No one's written about it. I don't think anybody's seen as many pediatric feet in their life as I have. There's no other reason for the first metatarsal to be short at birth, except for a longitudinal epiphyseal bracket. Now, all right, so for someone who's treated thousands of pediatric foot deformities, I can look at the x-ray and I know it's there. So most people aren't going to have that kind of experience. I would not fault one at all with getting an MRI. This is one case where MRI beats out CT scan for making the diagnosis. So get the MRI if you're suspicious. If it's really short, you know it's got to be there. If it's slightly short, just get it, because the alternative is to ignore it and then have the negative consequences of having left it there. So the reason I keep talking about MRIs and why I don't get them is, number one, most of the time they're not necessary for foot deformities. But number two, in the United States, they're incredibly expensive. For a baby in the United States to get an MRI, which would obviously require sedation or an anesthetic, it could be $5,000 to $7,000. So I think, I study x-rays because I can't see spending $5,000 to $7,000 on an MRI, but I know that's not the case around the world. And, it's only money, but if you can make the diagnosis with x-rays, go for it. If you want help, especially your first few times around, get the MRI, convince yourself of what's there, and maybe learn something from the experience as well.
Yeah. Another question is there. The Ranjit asks, how do you manage the Hallux varus with the clubfoot? Because we'll see some cases with Hallux varus, even treated and untreated clubfoot also.
Yeah, that's probably due to a tight abductor hallucis. And in my experience, it often settles down with time, but sometimes you just have to just keep a stretch on it because it's a muscle problem. It's the abductor hallucis. It's not typically a bone or joint problem. And it's often dynamic. The toe looks pretty straight normally, but when the child walks, they pull in. So I believe that the abductor fatigues over time. I think each case needs to be assessed individually.
Okay. So one more question. When there is a metatarsal is angulated or DMMA is negative with incongruent joint with subluxation, what would you address the first? Would you address the joint or would you address the metatarsal or you address all together?
Well, then I would take the experience with juvenile hallux valgus. So in juvenile hallux valgus, there's typically a high DMAA. There's too much valgus orientation of the metatarsophalangeal joint, and typically the joint is congruous, as opposed to adults who more commonly have a normal DMAA and a joint subluxation. So again, adolescent juvenile hallux valgus, the opposite, is typically a congruous joint with a valgus deformity of the metatarsophalangeal joint. Adults, normal DMAA and a subluxated toe. But you have to treat what you see. So if it's a child with congenital hallux varus, negative DMAA, and a subluxated toe, I would do combined procedures, correct the bone deformity, and align the toe, and then pin them all like a shish kebab.
Yeah. And it is the very important question for all the fellows, because in most of the books written the farmer's procedure, what you have shown the drawing pictures on this case, what is the role of farmer's procedure now? Like it's making the syndactyly between first and second ray.
I think that the farmer's procedure is quite elegant, and it makes a lot of sense. If that toe had undergone what I would have done, which is resect the longitudinal bracket and align the subluxated bone, I think that moving the soft tissue around would have perhaps complicated things. Again, the medial side of the foot, once you remove that abnormal tissue, is going to be raw bone, and moving the flap around might cause it to stick. I don't know. I just think I wouldn't have done it that way because I would be concerned about sort of too much surgery on the toe, too much change in vascularity, and how the flap might interdigitate into the resection cavity on the medial side. So I would have done the resect just a wedge of soft tissues in the web space, and if this was necessary, after aligning the toe, do a Z-plasty of the skin. So Z-plasty and remove a V. But again,
okay. And
one of the question, see, one of the salient feature of farmer's procedure is that you fuse carry out a syndactyly between the great toe and the second toe. And that's probably because we want to prevent the recurrence. So if you are not doing that, do you think that recurrence rate will be more in without syndactyly?
well, again, and I'm talking this through because I don't know if I've ever done a farmer's. This metatarsal is too short. If you syndactylize the great and second toe, then you're going to have a really hard time lengthening that metatarsal later on. You're going to have to take it down in order to lengthen the bone. It'd be better to risk some recurrent medial displacement, but not prevent yourself from lengthening the bone. This bone, again, it must be like 2/3 as long as the second metatarsal. It has to do a lot of lengthening. You have to do a lot of lengthening on this. And if the toes are tied together, you can't do that.
No, this is a different case because this
Oh.
is a congenital hallux varus with longitudinal epiphyseal bracket. So this is different. But if the first metatarsal is of normal length, means there is no epiphyseal bracket, in that case, do you suggest to carry out the syndactylization of the great toe and the second toe, or you don't do that?
No, I haven't seen it. I haven't found it to be necessary.
Okay. And do you use that flap which is shown over here, like the flap from the web space to cover the skin on a medial side?
No.
No. Okay. Then how do you cover? Only by the Z lengthening?
Yes.
Okay. Okay.
But I mean, the farmers is a recognized procedure. I just haven't personally found a reason to use it, and I have not been disappointed in not using it.
Yeah.
Yeah.
So
Yeah,
do we have
you-
more case or?
No,
Yeah,
that's
it's
it.
done.
Oh, I'm sorry. Oh, I think we're over time. This just came to me this morning. Short limb by a centimeter or so in a baby, and this foot longitudinal. So it's a 3-rayed foot. It's a short limb. This is hemiatrophy. Hemiatrophy. The fibula is of normal length, so it's hemiatrophy. With hemiatrophy and a 3-rayed foot, you can almost guarantee that there's a ball and socket ankle and a subtalar synchondrosis that will be a subtalar synostosis. The same kind of foot and ankle that you see in fibula hemimelia, except the fibula is present here. This is 4 toes, but the medial one is abnormal. And I can't see whether the second toe has 2 phalanges or 3, but it doesn't matter. The second toe from the medial side is the one that's lined up with the delta phalanx, with the longitudinal epiphyseal bracket. Management for this: remove the extra toe, the medial one, and resect the abnormal cartilage of the longitudinal epiphyseal bracket. Yeah, so there were 2 great toes because there were 2 phalanges of the most medial and the second toe. Okay, that's all I got.
Yeah, I think that in this presentation, you really showed us how to recognize the longitudinal epiphyseal bracket and how to carry out surgery. So that was really a great learning point for all of us. And you saw some of the like patient who have been operated, but one of the pathology is missed, and that would be probably resulting to disproportionate height between the first and the second metatarsal. So thank you very much for sharing your vast experience on this point and making it very clear that even without MRI, you can diagnose this condition. Thank you once again for sharing your experience with us.
Well, thank you for inviting me. I was love doing this.
Yeah. Thank you. Yeah. Bye-bye.
Bye-bye.
Thanks. See you.
Bye.